Well, hi, I'm John Halamka, the Chief Information Officer at Beth Israel Deaconess and Harvard's Professor of International Healthcare Innovation. And I wish I could be with you today, but the challenge of being an international professor is that I have to be in 3 or 4 countries at the same time. My friends at ANSI have asked me to talk about healthcare standards, challenges, and emerging solutions. I'm a very requirements-driven person. And so what are our requirements? What are our problems to be solved? Well, as I'm sure you know, the United States spends 17% of its gross domestic product on healthcare. And so that means we have ever-increasing costs. And yet our quality and outcomes are not as good as other countries that spend even 2/3 less than we do. We also have an aging society with more people requiring more care and fewer people paying into the system. So that's a challenge. We've tried to engage patients and families over the last few years through several federal regulatory efforts, and we've not given patients and families really the tools they need to navigate our healthcare system. If a loved one has a problem, where do you go? An emergency department, a primary care physician, a hospital? It's a bit hard to know. That compounds our problem with quality and cost. We have automated our hospitals and doctors' offices. In fact, 90% of doctors' offices and hospitals are fully digital. However, we've created incredible burdens for our care providers. You could easily say that 50% of each caregiver's day is spent with patients, and 50% is spent with a keyboard. That's a burden that's just overwhelming. We've tried to share data from doctor to doctor and hospital to hospital and from providers to patients. It hasn't gone completely well because there's a lack of enabling infrastructure. In effect, we asked doctors to drive but didn't give them any roads. So I'll describe some of the efforts we need going forward. And finally, there is significant variation in healthcare practice in our country. I'm an emergency physician. We all have been trained as artists and apprentices. And depending on the clinician and their training, you'll get different costs and different quality. We need more uniformity. I'll also talk about how to address that challenge. So over the course of the last 8 years, as I said, we spent $31 billion, and we have achieved some remarkable adoption, probably faster than any other industry has automated. However, 50% of our clinicians want to quit because of the overwhelming burden of these digital tools. Just too much to do, not enough time, and a lack of usability. And patients, although they've been given portals, might have 4 or 5 of them. You log into the portal for your primary care doc and your emergency physician and your hospital and your skilled nursing facility, and they're just not used that well because they don't bring that much value to the patient. At the same time we're sharing more data with more people for more purposes, our security challenges are escalating. Just look at the Equifax issue or the recent Deloitte hacking. It turns out that keeping large amounts of data secure is difficult for any industry. And finally, because of a regulatory burden, a lot of our major vendors have not had the time and resources to innovate. So the last several years, we've actually seen a reduction in the pace of innovation, and we really need to learn from the past and not over-regulate the future. We need to permit innovation while standardizing, and that's a bit of a challenge. So some emerging trends for you as our final requirements, and then I'll talk about the standards that I see, both those that we have already implemented and those we need to implement. Although the United States has 5 major electronic health record vendors, Epic, Cerner, Meditech, Athena, eClinicalWorks, I don't believe in the next few years those 5 companies will be the centerpiece of innovation. I believe it will be the 26-year-olds in the garage, innovating and in an agile fashion, solving niche problems. But then their products and services will layer on top and integrate seamlessly with the major electronic health vendor products. That ecosystem is very analogous to the iPhone and the App Store. Create a platform, the EHR, but then enable, without a huge amount of expense or time, innovators to layer on top of it. So we'll need standards for that. We will, as a country, need to solve certain infrastructure problems. So for example, if your name's John Halamka, it turns out to be quite simple to match my records from place to place because there are only 13 Halamkas in the United States. But imagine your name is Maureen Kelly and you come from an Irish-American neighborhood. It's impossible. So we need a nationwide patient matching strategy. I didn't say national healthcare identifier. I mean, that might help. Could be biometric, could be some machine learning algorithm, it could be face recognition. All kinds of things are possible, but a nationwide patient matching strategy. We need an electronic directory of all of our caregivers and the electronic addresses as to how to reach them. We need common policies and governance for deciding how data gets exchanged and consent gathered and what purposes data can be used for. We'll see also an emerging trend of cloud-hosted decision support. For example, Harvard has created a library of evidence that's open source as to best practices and care plans that can be used by any vendor for any purpose. So imagine, as we think about going from patient to patient and doctor to doctor, we're seeing care plans that are actually evidence-based and similar. And that becomes an open source cloud-hosted infrastructure. There's absolutely an urgency to move from fee-for-service to what I'll call pay-for-value, pay-for-quality, pay-for-outcomes. Because in the United States, we've seen if you pay a doctor for doing more, they'll do more. 15% of lab tests and radiology tests in the United States are redundant and unnecessary, and that's not sustainable, especially in an aging society. As I've said, although government regulation can be a catalyst, we're at a period of time where potentially a reduced pace of government regulation will actually help us advance our innovations. Let the private sector lead the next couple of years based on the foundation of regulations that we've had in the past. So those are the problems, some of the requirements, and some of the to-dos, but what about the standards that are necessary? So in healthcare, 3 kinds of standards. What I'll call vocabulary, security, which is also transport, and content. Vocabulary. Well, I believe you have high blood pressure. Another doctor may say, oh, you have hypertension. Another doctor may say, you have elevated blood pressure. We've all just said exactly the same thing using different terminology. The only way that data can be exchanged, provider to provider, provider to patient, hospital to provider, etc., is by having a common language. And SNOMED CT is that common language to describe signs and symptoms and problems. And we're seeing more and more in the United States SNOMED CT adopted within the electronic health record to create uniform language. Now, what if you have a lab test? Well, maybe you got a glucose. Well, there are many different kinds of glucoses. There's a blood glucose and a urine glucose and a spinal fluid glucose and a glucose that's done on a Roche analyzer versus a Sigma analyzer. You need a common vocabulary to describe each lab test and the method used to measure. LOINC codes, L-O-I-N-C, are used for laboratory standardization, and again, used now more and more across electronic health records in the United States. How about medications? Tylenol. Well, no, I'm not on Tylenol. I'm on acetaminophen. No, I'm not on acetaminophen. I'm on Panadol. All 3 are exactly the same chemical. RX norm is a mechanism of standardizing not the drug name or its package size, but its chemical. Also used in electronic health records fairly significantly. So if I were to look at the one great achievement over the last several years, it's that we have succeeded at standardizing the standards for vocabularies with LOINC RX norm and SNOMED CT. What about getting packages of data from place to place? Well, on the web, of course, there's simple mechanisms of doing that. The web pages where you upload your pictures, for example, are using a simple RESTful protocol and a simple HTTP post command to get that picture uploaded. In medicine, we haven't really quite used that simple RESTful approach. There have been mechanisms of data exchange, such as the direct protocol, which is a mechanism of using secure email from place to place. But admittedly, it's a little clunky. So as a country, where are we going? We are moving as Amazon, Google, and Facebook have moved to simple web-based secure approaches, RESTful protocols using JavaScript object notation, and OpenID and OAuth as mechanisms of authorization and authentication. So imagine this, that for security in transport, healthcare simply uses the same standards the entire internet has used for electronic banking and e-commerce. And that's an important direction to head in. There are a number of initiatives and a number of organizations that are working together in the United States on such security and transport standards, direct trust, care equality, and a number of standards organizations like HL7 and the Argonaut Initiative to help us adopt those standards more widely. Well, and finally, what about content standards? Now, content is a payload of stuff, your medical record from your visit today. Well, there's probably two ways we need to represent content. One would be a summary of everything that happened to you in a doctor's office or in a hospital. And the clinical document architecture, the so-called CCDA document, has been part of national standards for the last couple of years for representing a summary. It's actually worked okay, but one of the problems is it has too much optionality. So it's relatively easy to create a CCDA document, but sometimes challenging to pull it apart and parse it because you're not quite sure what's going to be in it. So I think you'll see over the next couple of years increasing refinements of the CCDA so that it's fit for purpose. As an example as to what Beth Israel Deaconess has recently done. Turns out when a baby is discharged from the neonatal intensive care unit, you need to include certain lab results and historical information about that baby, but also certain characteristics about the mother and the birth if a primary care physician is to continue the care of that individual post-discharge. So our CCDA has been very highly constrained to contain all the useful information for the next provider of care. And we've done similar work with transitions of care, and we've done similar work to help us measure quality across multiple heterogeneous electronic health records. So CCDA with refinements and constraints on optionality. CCDA is fine if you want to push a payload from place to place. But what if a patient comes to an emergency physician, right? You didn't make an appointment to see me, at least I certainly hope not. Well then, what you'd want is the ability to do what I'll call query response. I, as an emergency physician, with your consent, will query your records where they exist and pull the data in real time. To do that, CCDA is not the standard. FHIR, Fast Healthcare Interoperability Resources, is the way to go. And FHIR, again, taking a playbook from Google, Facebook, and Amazon, is JavaScript object notation over a RESTful HTTPS connection that allows me to query a healthcare source and with appropriate consent and trust and security, retrieve that information in real time. You'll see more and more deployments of FHIR over the next couple of years for a variety of use cases, everything from care coordination to helping patients navigate, to helping us measure quality, to helping us get evidence. Because right now, remember, with doctors being trained as apprentices, there isn't uniform decision support. With FHIR, imagine that we get cloud-hosted decision support and care planning that enables an electronic health record to deliver a common set of recommendations to every patient, regardless of their care location. So there you have it, a set of recommendations which is embrace vocabulary standards, ensure we continue to adopt the web and use it as a secure transport mechanism with appropriate controls, increase the use of CCDA with constraints, and embrace FHIR. And all of that will help us as a country solving some of the challenges that I outlined at the beginning. So again, I hope you guys have a great conference. ANSI is the place for standardization, and I'm sure all the things I outlined will be carefully coordinated by ANSI in the future. Thanks very much.